You know, IV catheters are an absolute lifeline in medicine, but they carry a pretty serious risk: infection. And the real head-scratcher for doctors isn't just treating the infection, it's diagnosing it in the first place. I mean, how do you actually prove that a life-saving device has turned into the source of a life-threatening problem? Let's get into it and try to unravel this critical diagnostic puzzle.
So here's what we're going to cover. First, we'll break down why this is such a tricky diagnosis to make. Then, we're going to explore the main techniques doctors have up their sleeves, the classic method that requires removing the catheter, and then two really clever approaches that work while the catheter stays put. We'll wrap things up by looking at why the debate over which method is truly best is, well, still a hot topic.
All right, so picture this, because this is a scenario clinicians face all the time. You've got a patient with sepsis, a serious bloodstream infection, but when you look at the IV site, it looks perfectly clean. No redness, no swelling, nothing. A blood test confirms there are bacteria, sure, but it doesn't tell you where they came from. So how in the world do you prove that catheter is your prime suspect?
Okay, so let's dive right into that diagnostic challenge, because pinpointing the source is way harder than you might think for a few key reasons.
For starters, like we just said, the insertion site can look completely normal, giving you zero outward clues. On top of that, the patient's symptoms, fever, chills, are just general signs of sepsis. They could point to a dozen other things. And the biggest problem? Even when a blood culture comes back positive for bacteria, that doesn't point a finger at the catheter. The source could be the lungs, the urinary tract, who knows? You really need more specific proof.
So the key to cracking this case all comes down to one crucial concept: quantitation. Think about it. Our skin is covered in bacteria. That's totally normal. So just finding some bacteria on a catheter tip doesn't mean much. It could just be contamination from the skin. The real diagnostic power comes from measuring how many bacteria are present. A really high number? That's the signal that separates simple colonization from a genuine active infection.
All right, let's talk about the classic approach first. It's called a post-removal tip culture, but it's got one pretty big catch. The catheter has to come out.
So here's how it works. First, the tip of the catheter is removed super carefully and cleanly. Then, it's rolled across an agar plate, which is designed to grow any bacteria that were living on the outside of the catheter. Then, that same tip gets dunked into a special broth to culture anything that might have been hiding on the inside. After about a day of incubation, the lab techs can literally just count the colonies. It turns a vague suspicion into a hard number.
Okay, that's great, but what if taking that catheter out just isn't an option? For a really sick patient, that central line can be their literal lifeline. You can't just pull it out to run a test if it's not safe. And this is exactly where diagnosticians had to get creative and come up with techniques you can do while the catheter stays right where it is, or in situ.
Now, the logic behind these in situ methods is actually beautifully simple, but it's super powerful. The basic idea is that the infected catheter is ground zero for the infection, right? It's the epicenter. So it follows that a blood sample drawn directly from that catheter should be packed with way more bacteria than a sample drawn from, say, a random vein in the arm, far away from the source.
The first in situ method is called differential quantitative cultures. I know, it's a mouthful, but it's really all about comparing the numbers.
So here's the deal. The lab gets two blood samples, one from the suspect catheter and one from a peripheral vein. They plate both and just count the bacterial colonies that grow. And here's the magic number. If the catheter sample grows at least 4 times more bacteria than the peripheral sample, a ratio greater than 4-to-1, then bingo, you've found your source. Some places are even stricter and look for a 10-to-1 ratio to be absolutely sure.
And check this out. The performance of this test is pretty remarkable. Its sensitivity, that's its ability to correctly identify an infection when it's there, is really high, somewhere between 78 and 94%. But its specificity is what's truly amazing. We're talking 99 to 100%. That means if this test comes back positive, it is almost never a false alarm. You can be incredibly confident the catheter's the culprit.
Okay, so the second in situ technique uses that same ground zero logic, but it measures something completely different. It's not about how many bacteria there are, but how fast they grow.
So for this one, blood from both sites, the catheter and the peripheral vein, goes into these automated culture bottles. The thinking is simple. Since the catheter sample starts with way more bacteria, it should grow faster and set off the alarm on the machine sooner. It's basically a race. And the magic number here? 2 hours. If the catheter bottle flags positive more than 2 hours before the peripheral one does, boom, you found the source.
So, just to recap these two really powerful in situ techniques, the differential quantitative method is all about comparing the bacterial quantity, looking for that greater than 4:1 ratio. The differential time to positivity method, that one's about comparing the bacterial growth speed, looking for that 2-hour head start. Both are just really clever ways to confirm the catheter is the problem, all without having to pull it out.
Now, with all these different techniques, you might be thinking, great, problem solved. But the reality in the clinic is, as always, a bit more complicated. And that leads us to our final point. The search for a single, definitive, gold standard test is far from over.
And this quote really hits the nail on the head. Despite how clever all these methods are, not one of them has emerged as the undisputed champion. Each one has its own costs, its own logistical hurdles, and its own challenges in interpretation. And what that means is the debate over which test is the right one for which patient, well, it's still very much a live issue.
So, this leaves us with a final, really critical thought. If there's no single gold standard, diagnosing these infections isn't about following some simple flowchart. It's about being a detective. It's about taking all the available clues, the lab results, the patient's condition, the whole clinical picture, and piecing them together to make a decision that's guided by sound clinical judgment.